Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome back Earl Stewart. He's an internal medicine physician. Today's Kevin MD article is Pancreatic Cancer, Racial Disparities. Earl, welcome back to the show.
Oh, Kevin, thanks for having me. Good to be
Uh,
with you.
All right. So tell us what this latest article about and the events that led you to write it in the first place.
Yeah, this is an article that is more of a passion project, I would say, than many of the articles I've penned before in the past, even for the Kevin MD blog. And over the years, I'm a practicing physician and I serve as medical director of health equity for my health system, which is the largest non-for-profit health system in the state of Georgia. And I've been keeping a running list of celebrities, individuals of fame in the African American community who have succumbed to pancreatic cancer. And that's something I started, I would say maybe about 5 to 6 years ago at the beginning of really transitioning jobs. And I started to notice a trend of just these really well-known, powerful public servants, musicians, just people of remarkable stature in the African American community, and many of them were succumbing to pancreatic cancer. I've also had some personal connections to this topic. As I mentioned in the article, I lost one of my mom's baby brothers to pancreatic cancer on Christmas Eve in 2013. He also had cholangiocarcinoma. And I've had some educators in my life, school teachers from my high school who also passed away from pancreatic cancer. And so I've started to notice this trend of just these very well-known individuals and some not as well known who are succumbing to this very treacherous cancer. All cancers are bad, but as we know, pancreatic cancer has a really, really high mortality risk. And the 5 year survival per data from the American Cancer Society is just over 13%. And so this article was sort of written to kind of be a clarion call to the medical community, the clinical community to really catch up with the data. And we really need guidelines that are sort of centered on that race specific data, how we're seeing more African Americans succumb to the disease.
So, for some context, what are some of the numbers when it comes to the racial disparities of pancreatic cancer?
Yeah, African Americans are 50 to 90% more likely to die from pancreatic cancer in comparison to their white counterparts. We see every year, and this is based on data from NIH and from the gastroenterology journals. Every year we see about over 62,000 individuals die. I know that was 2020, 2023 data, 2025 data, closer to 65,000 individuals being diagnosed with pancreatic cancer across different racial groups,
Mhm.
but about 50,000, 40 to 50,000 pass away every year from this cancer. So you can see how, the data compare to those being diagnosed versus, those who actually succumb to the disease. About one in terms of lifetime risk, and this is based on data also from the American Cancer Society, in terms of lifetime risk, about 1 in 60 women will be diagnosed, and in terms of gender related data, and about 1 in 56 men. Men are almost twice as likely to be diagnosed with pancreatic cancer than women will. So it's certainly more common in men. And there's been specific data about how to protect African American men and detect it early in African American men. As we know, as almost all the time, as soon as we diagnose pancreatic cancer, it's already metastasized. And so the purpose of the article, given my work in health equity, was really to call our attention to something that we need to do for the future of medicine to better take care of our patients who are at higher risk of this particular cancer.
And I just want to echo what you said. By the time a patient presents with the symptoms of pancreatic cancer, it's already at a relatively late stage, unfortunately.
Yes.
Now, you mentioned that disparity of the diagnosis of pancreatic cancer, especially in Black patients. What are some of the reasons you could speculate why that is?
We don't really know, but it really is all conjecture and speculation. maybe there's some genetic risk there. We do know if individuals have BRCA mutations, particularly BRCA2, if they have a family history of Lynch syndrome, which we know by its scientific name is hereditary non-polyposis colorectal cancer. We do know also maybe smoking trends, tobacco use, smoking cigars or cigarettes is an independent risk factor for the development of pancreatic cancer. Also, new onset type 2 diabetes after the age of 50, as well as a history of chronic pancreatitis, which for the most part is tied to alcoholism, heavy alcohol use. Some of the data suggests that, African Americans may have a higher preponderance of those risk factors and be more likely to develop a pancreatic cancer as a result of that. But also we know BMI is a big component as well and can be considered itself an independent risk factor for the development, higher BMI, an independent risk factor for the development of pancreatic cancer.
As you know, the U.S. Preventative Services Task Force gives pancreatic cancer, I'm looking at it now, a D rating, meaning
Yeah.
that it does not recommend screening for pancreatic cancer. So, what's your reaction to the guideline, and what would you like to see done?
As medicine becomes increasingly individualized, increasingly genomic, if you will, take a more individualistic approach, right? There are some recommendations out there for individuals who have more genetic risk factors like BRCA and Lynch syndrome. We do know that those exist, and there are some surveillance programs. We even have one here in Atlanta with the Piedmont Health System that I've started, referring patients to screen individuals who are higher risk and who need additional surveillance. But I think the guidelines really miss where we are in terms of the data. We have the data, we know the data. Why aren't the guidelines following it? And I'm not knocking our, very reputable guideline making bodies, but this is where the discrepancy exists between what we see clinically, what we see experientially, what we see even in our own families, in our own communities. And as a Black man, my family has been touched by pancreatic cancer disproportionately as well. And so, when are we going to catch up to what we're seeing in the community? Now, it is not lung cancer, it is not breast cancer, it is not colon cancer, right? Those are certainly more prevalent and certainly more incident. But we do know it is the third most common cause of cancer-related death in the United States, and it still impacts people significantly. And as I mentioned in the article that that you accepted in October, I think we really fall behind, and there are so many different people who would benefit from early detection, additional surveillance, research endeavors to help us get to the point where we can develop more specific guidelines that include the race-based data. And so that's where we are. I think the current USPSTF guidelines sort of fall short.
So, tell us about what you do in your own practice in terms of the patients that you select for screening, as well as the different tests that you would order for those who would have a higher than normal risk of pancreatic cancer.
Yeah, absolutely. So we know that, and we're very fortunate in our health system, the WellStar health system, and other large comprehensive health systems to have specialists, even academic medical centers, to have specialists who can do EUS, endoscopic ultrasound, which is one of the reputable, safe ways of, carrying out screening and early detection for this particular type of cancer. We can order abdominal MRIs. I remember as a resident at Brown, we had some discussions on rounds once about a patient whose wife was just remarkably persistent when it came to, he had some symptoms. I believe he had painless jaundice, which is a common symptom of pancreatic cancer, particularly adenocarcinoma in the head of the pancreas. And we got a CAT scan, didn't show anything. We got some additional imaging with iodinated contrast, really didn't show anything. But his wife was persistent about getting an abdominal MRI, and we got the abdominal MRI, and sure enough, it showed a very, very small head of pancreas mass, which turned out after biopsy to be pancreatic cancer. And so he was diagnosed, fortunately, at stage one, which is where we want to diagnose people with this cancer. And so since that time, that was many years ago, that those are two of the modalities that I find to be extremely important and useful for patients for whom this is apropos. right? And so individuals with painless jaundice, individuals with acolic stools, individuals with abdominal pain, individuals with these risk factors that we've already previously discussed, especially when medicine, especially primary care, internal medicine, as you know, as a fellow internist, it's a puzzle.
Mhm.
And so when we put all these pieces together and many of these boxes are checked, it's important for us to act. It's important for us to not just say, well, there's no national guideline for this from the American College of Gastroenterology and no national guideline for this from USPSTF. We treat the patients, we don't treat the guidelines, but the guidelines are guidelines. They're helpful in situations where we need, clinical decision making help and expertise, but they're not the be all end all, especially in situations like this where we don't have national guidelines to screen the majority of the population. As I say in the article, I'm not calling for all Black people to get CT scans at a certain age, but we need to kind of single out the fact that Black people, Black Americans, African Americans, are more likely, just based on that race specific data, to be encumbered by this cancer than other racial groups and ethnicities. And then from that specific population, let's talk about how we can single out those at highest risk with these risk factors. That's what we're calling for. And that's what I look for in my practice.
Now, from the perspective of the guideline makers, why has it taken them so long to make any changes when it comes to individualizing pancreatic cancer screening? I was just looking at the U.S. Preventive Services Task Force. It hasn't been revisited since 2019. So,
Yeah.
what do you think some of their arguments are, and how would you rebut those arguments?
Yeah, I think definitely around the argument of being race specific. We've seen some of that happen and be operationalized as it pertains to prostate cancer. We've seen some of that being operationalized as it pertains to even colon cancer before USPSTF updated the guidelines to screen all adults a few years ago at 45 instead of 50. The ACG, the American College of Gastroenterology, really led the way in terms of starting African Americans at 45 who are average risk in comparison to other ethnic groups and their white counterparts. But I do think USPF, to your point, they have a long, painstaking process. But I think what's going to really get them to that point is seeing other guideline making bodies, major specialty societies in gastroenterology and oncology leading the way in
Mhm.
terms of giving us a national guideline for this specific ethnicity or race of individuals, and then perhaps they'll be able to follow along because the data are there. And I think we cannot ignore the fact that we're seeing time and time again. Even there was a large review article published in that I consulted for the purposes of writing the article. It published in 2023 in gastroenterology, and it pretty much called out these disparities that exist in pancreatic cancer screening, diagnosis, and early detection. And so I just think USPSTF needs to follow suit. They need to look at updated data. They need to consult experts. They need to follow what we're seeing in clinical medicine. I know it's not always easy. It takes resources. Certainly this current geopolitical climate is really impacting our ability to be more individualized in terms of race specific issues, ethnicity specific issues, but we still have to, you know, go and grow in terms of practicing medicine and take care of our patients as best as we can.
How about patients who may be listening to you now? What kind of things in their history, what kind of symptoms should they have in order to perhaps ask their clinician whether they would be a candidate for pancreatic cancer screening?
That's a great question. I do think most of these conversations take place in the confines of an annual physical or preventive visit. And so I would call on patients, number one, to know their family history.
Hmm.
Number one, to be reminded of the risk factors that we've already discussed earlier in today's interchange, and not be shy to approach these discussions with their primary care physician. Not be shy in terms of discussing risk factors and family history, even among themselves in their own families and in their own communities. And asking these questions, what's my risk of pancreatic cancer? is there a way, because I have a strong family history of pancreatic cancer, I can be tested for Lynch syndrome and genetic mutations associated with it, or I can be tested with the BRCA. We order BRCA all the time through the BRCA Sure test in my office. A lot of times patients will come in and request it. We don't have a guideline to screen most people for this, right? But they'll come in and request it, especially if there's some family history of breast cancer and first degree relative. And so we always ask the question, do we know if this is a hereditary type of breast cancer your mom had? Or was this just acquired or due to environmental exposures? And so that's where the conversation starts. I call for patient empowerment in these discussions as well, because we as physicians, we're going to always strive to do our best by our patients, but we need the input of patients in that patient-physician relationship. It's a 50-50, not 100-0. And that's the way I've always looked at it. And I love when patients are educated and empowered. So it doesn't hurt for them to come in with their list and ask these appropriate questions at the types of visits where it's necessary. These are the conversations that we're having in annual physicals. And I know there's been a lot of vitriol written about whether or not the annual physical is still necessary, but we get a lot of good information from those visits. And as a practicing physician, I still appreciate them.
We're on to Earl Stewart, internal medicine physician. Today's Kevin MD article is Pancreatic Cancer, Racial Disparities. Errol, let's end with some take-home messages that you want to leave with the Kevin MD audience.
Yes, thank you, Kevin. Pancreatic cancer disproportionately impacts Black Americans. We need, and I call on guideline making bodies from the American College of Gastroenterology, the AGA, CDC, NIH, the American College of Physicians, my own professional home, to sort of lean strongly into the data that exists and really take a race-based approach to help stem this tide that we've been seeing for several years. Personally, clinically, professionally, and really throughout the African American populace here in the United States. I call on patients to ask the question, to know their family history, to have these discussions, to be empowered enough when they present to their physicians to have these discussions, and to listen to today's podcast and to know that there are those of us out there who are seeing these trends and we're paying attention to it, we're writing about it, and we're speaking about it publicly, and to understand that these inequities still exist. And unfortunately, with what we see geopolitically, we have to, take alternative approaches to getting the word out, where so much has happened from a policy standpoint and in terms of, sort of stifling these conversations around race specific health issues. But I do think it's important for us to, tell the patient, we understand what you're going through. While there is no national guideline to screen for pancreatic cancer yet, we are calling on important bodies that make these decisions, that help physicians help you
Mhm.
to, to act and to do what we have to do and advocate. This is all about advocacy, right? The whole article is really about advocacy for the marginalized and the people who would benefit from these actions the most.
Errol, thank you so much for sharing your perspective and insight. Thanks again for coming back on the show.
Good to be with you, Kevin. Thank you. Happy New Year.
Happy New Year.